So here's your lecture on your antibiotics treating your infectious diseases, chapter 24. This is the audio version. This is probably the class of drugs that everybody wants us to prescribe the most. So here's your overview. Resistance, beta-lactams, penicillin, cephalosporins, fluoroquinolones, on and on and on and on and on. Alrighty. Whole array for us to choose from. Okay, so here, what's the cause of antimicrobial resistance? Too many antibiotics, right? Recent antibiotic use. You'll have somebody that comes into your office and they've got a cold, sore throat, and they're staring you down for that beloved Z-Pack. So, you finally break down and you give it to them. They come back 2 weeks later and tell you have a sinus infection. And they really do have a sinus infection. Now what are you going to do? You have a problem. Because now you have somebody who's set up for drug resistance because they've taken an antibiotic in less than 3 months' time. So less is more, and if you don't have to give one, most things it is okay with watchful waiting, adults and kids alike. Same thing, very old, very young, drug resistance happens, daycare center, immunosuppressed individuals, comorbidities, nursing homes, wherever there's a large amount of population, there's antimicrobial resistance. Every antibiotic class has a resistance to organisms. Every one. Alright? Alright. So, beta-lactams and penicillins. Beta-lactams is when that lovely ring gets placed around your organism and you need something to break through it. So then you have your drugs like Augmentin. Okay, so it says penicillins. Alright, you have your penicillins that treat strep, enterococcus, and staph. Right, and then you have your amiopenicillins. And you guys can read all of this. And then you have stuff for H. flu and can't even think. You have your stuff for H. flu, enterococcus, and all the gram negatives. All right. I mostly wanted to talk to you about first drugs we use with the lower respiratory tract. Strep pneumoniae, as you've learned in your pneumonia PowerPoint, is the most common form of pneumonia. And what is strep pneumoniae? It's gram-positive cocci and clusters, right? That's what strep pneumoniae is. So you need a drug that's going to cover a gram-positive. So what kind of drugs are those? You need to think you're going to have a patient who comes in your office and they have no comorbidities. You don't worry about drug resistance. Believe it or not, you can actually put them on a MOX. You can use a 500 milligram Q8 hours dose for that. You can also use a Z-Pack. You can use a macrolide, which is Z-Pack, that's fine. And then you save the big guns, your fluoroquinolones, your Levaquins, for those patients that have chronic bronchitis, COPD, and your smokers, or also if they're drug resistant. So you want to save the fluoroquinolones for last. But strep pneumoniae is gram-positive. So what you're going to need to know is your most common organisms for your diseases, strep pneumoniae for pneumonia, and what it is, gram-positive, and then what covers. So that's the biggest thing. Your next form of pneumonia that's most common is H. flu, which is a gram-negative bacillus, right? It produces that beta-lactamase, so therefore you need the beta-lactam to bust through that ring to treat the organism. So the effective antimicrobials, those with activity against gram-negative organisms, are and stable in the presence or active against beta-lactamase, are your cephalosporins, your moxicillin with clav, which is Augmentin, any of your macrolides, respiratory fluoroquinolones, which your respiratory fluoroquinolone is not a Cipro, it's a Levaquin, It's a Avalox and Gemi too. It's Moxie, Levo, Gemi, Floxacin is what they are. Um, those are your respiratory fluoroquinolones. Also, you have your tetracyclines, including Doxy. Doxy is a great drug, not to be discounted. It can be used from anything from sinus infections to skin problems. So, always when you have somebody with a lot of allergies, sometimes you are just pulling that Doxy right out of your hat. So, H flu is the most common with a smoker, by the way. That's what you're going to have. You're going to run into H flu with a smoker. So, you're going to give that smoker um, an Augmentin, a Levaquin, a Doxy, or actually even the Z-Pak. You can if it's somebody who's younger. You can also use your clarithromycin, which is a macrolide as well. So then once again, you need to know your organism, H. flu, common in smokers, for pneumonia, gram-negative bacillus, what's going to cover. Gram-negatives can produce that beta-lactamase, and it's about 80% that do. So that's how that's what you want to grab for, those types of drugs. Oh my gosh, can't speak. Okay, so then you have M. pneumoniae and C. pneumoniae, and they're not revealed on a gram stain, so we have no idea what they are. These are your atypicals. All right, so these are effective antimicrobials, are macrolides, respiratory fluoroquinolones again, tetracyclines, once again, including Doxy. Ineffective antimicrobials are the beta-lactams and your cephalosporins and your penicillins. So, once again, these aren't by gram stains. These are your atypical pneumonias. Yes, they're on the board. So, this, once again, you have to know your organism, your pathogen, your description, which is your gram positive, gram negative, and then what are you going to treat with. All right. Okay. All right, let's see what we can do. This is just more about beta-lactams. It's important for you to know why. Let's talk about beta-lactams, Augmentin being one of them. Big, big, big adverse drug reaction is C. diff. So, we're going to be dealing with a whole lot of elders, aren't we? A whole lot of elders, whether you have a job like mine where you're dealing in nursing homes and rehab centers, or if you're even having elders come into your office. It's real tempting just to throw on an Augmentin because it kills just about everything, but it also kills your gut. Eats up every nice flora in there, and you have your elders all of a sudden now with C. diff. Now what are you going to do? Now you've got a big problem on your hands. You've now got somebody who's really sick, and now you need to put them on Vanco and Flagyl. So you got to be careful with the use of the beta-lactams too. Lots of side effects. Penicillins. These drugs are usually great in primary care. This is the first line drug for otitis media and sinusitis. Um, please don't throw Z-Paks at your patients for sinusitis. There's an algorithm for sinusitis. It goes amoxicillin, amox with clav, which is Augmentin. Then you can try a macrolide, but actually it goes to like a Levaquin. So you're going to hear a lot about rational drug selection. Okay. More about penicillins. We all know the adverse reactions of any of these meds or allergies. You have your cephalosporins. You have your first, second, and third generation, fourth generation. So you have to see which ones work against which bacteria. More on cephalosporins here. Adverse reactions. Okay, so what do we use a cephalosporin for? Strep pharyngitis, UTIs, and once again, these can cause C. diff and lots of diarrhea. Fluoroquinolones. There's not been a new drug since the fluoroquinolones there has not been a new antibiotic since the fluoroquinolones have come out. It's got to be at least 10 years now. Just remember, all fluoroquinolones are not recommended, and I'm sure it's a test question everywhere you look, not recommended for children under 18 years of age. And now there is increasing risk to resistance due to overprescribing. And This one is resistant to TB, by the way. But fluoroquinolones, well absorbed in an empty stomach, lots of black box warnings. I want you guys to think about this too. There's something that we haven't talked about yet, and I'm going to talk about it in a PowerPoint in your week 4. And this is called your cytochrome 450 isoenzymes. And we're going to talk a lot about that, and this affects things like your fluoroquinolones because there's a lot of adverse reactions, and it really just totally makes them worse. So the black box warning on fluoroquinolones, test question everywhere. Tendinitis, tendon rupture. A lot of times, too, you'll talk to patients and they will complain of awful joint pain, although you don't see it anywhere. So people feel dizzy, they have renal failure, they have aflutter, need to avoid them in pregnancy, and no one can take them under 18. It's just the way it goes. Here's your clinical uses: UTIs, pyelonephritis, infections, chronic bacterial fasciitis, you name it. It treats some great stuff. Penicillin-resistant strep pneumoniae, skin infections, bone and joint, everything. This was like the drug that everybody thought was the ace in the hole, and now we've just used it to death. And you know, we're kind of in trouble. We haven't come out with anything new in 10 years, so now what? I think Cipro is probably the most overused, followed by Levaquin. Patient education, that's that. Okay, so I'm going to back up a little bit to fluoroquinolones and just want to talk a little bit about fluoroquinolones. If you have somebody who's really quite ill, there is Levaquin comes in 750, 500 doses. This is the only drug, antibiotic-wise, that has the same dosing, both PO and IV. And actually, of course, IV gets there faster, but it's pretty much, it works pretty quickly. So that is a good thing about it. Clinda is another great drug with another really bad black box warning: severe colitis, erythema, thrombocytopenia. So what are you going to use Clinda for? So this is for MRSA. You can use this infections in penicillin allergic patients, drug-resistant infection, dental infection, second-line therapies for aerobic activity, pregnancy, children, okay? So the biggest one is the colitis, ulcerative colitis, actually, with the Clindas. This is everywhere. So anytime you have anybody that you're putting on any kind of an antibiotic, especially Augmentin and Clinda, you have to pretty much, if they're not going to take an over-the-counter probiotic, you need to prescribe one, absolutely, to ward off all this problem. Besides, tell them to eat yogurt whenever they can, whenever they eat. It's almost irresponsible not to. Alright, let's see. Hang on here. Macrolides. These are our erythras, our clarethras, which is Biaxin, and your beloved Z-Pak. Potent inhibitors of CYP450-384. You don't have to worry about that today so much, but you're in week 4, since you have a test week 4, just going to post an audio, and it's just going to be about cytochrome P450. And it's for your knowledge base, and it'll put some things together. You'll see this in the drug books, and you may be wondering what it is. And I know it's been in your readings, but it doesn't drive it home how if there's a drug-to-drug interaction, it is because of cytochrome P450 isoenzyme. Okay. So anyway, we're not going to even talk about it. So let's go to the macrolides. Macrolides are really hard on your stomach. You'll have people complain about erythromycin all the time, that they have vomiting and stomach pain. Same thing, they cause rashes. So here's what we treat with erythromycin, though. Chlamydia we treat with, and if you have a kid who gets pneumonia, chlamydia pneumonia, a baby, that's with erythro. I guess you could probably treat with azithro, meaning Z, your lovely Z-Pak, although it's not a Z-Pak if it's for a kiddo. But erythro is the treatment. Pertussis gets treated with erythromycin as well. H. pylori is Biaxin. Chronic bronchitis you can treat with your Z-Pak. But actually we're going to talk about bronchitis. 99% of all bronchitis is viral. Okay, these are more about your cytochrome. Okay, let's go to your sulfas. So you've got all your sulfas, your Bactrums, your macrobids, right? Sulfa, you think UTI. Sometimes that's true, sometimes that's false, but it's great against E. coli, and for most things that cause UTIs. All right, same thing. They all cause dizziness. They all cause diarrhea. They all cause stomach upset. So your big one that you need to is everybody needs to look up what G6PD deficiency is. This is something that is a genetic deficiency. It runs in families. I'll just give you a hint. They'll never be able to take Lasix. They can't take Tylenol. They can't take sulfas. And what is it? And it usually comes from an African population. And we'll talk about that also later. And if it's in your test, we'll talk about it sooner. Here's your sulfa. Usually you're treating with for UTI or skin. Skin, a cellulitis, things like that are your sulfas. And these others are pretty, let's go back. I want to go to tetracyclines. Tetracyclines, okay, so we know nobody, although it says tetracycline, doxy is a first-line therapy for trick, but cannot give this to someone pregnant either. So who do we find trichomonas in? Somebody pregnant half the time. So anyway, tetracycline, minocycline, and doxy are used to treat asthma very often. At 100 milligrams, you give a loading dose of 100 milligrams BID one day, and the rest they can stay on the dose of 100 milligrams PO daily for acne. As in primary care, you're allowed to treat for that. That's fine. Use doxy or minocycline for that. Always taken with food. Cannot be given in pregnancy because you will have a baby with discolored teeth. So no doxy, tetra, or minocycline in pregnancy. I'm sure you might run into that somewhere. Alright, vancomycin, similar to gentamicin, damages hearing, damages kidneys. Great against MRSA, right? Vanco. Okay. Clinical uses of Vanco: gram-positive infections, resistance to other things. C. diff is treated with Vanco. Weeks and weeks and weeks of Vanco. So there you go. Alright, so in red here, no matter what antibiotics prescribed, if your patient is on birth control pills, instruct that patient to use a backup method of birth control until the next cycle. So I think we all know by now that we have to pay attention to things. And mycobacteria, antimycobacterial. These are your INHs. This is for TB. I don't know if we have a lot of TB on this test, but we eventually will. Obviously we do. Okay, so patients taking INH should also take vitamin B6 to prevent the development of peripheral neuropathy. So at some point we're going to have to talk about this as well. Any kind of drugs, INH, anything, they all have so many side effects. And your antivirals. So that's your acyclovirs, your vanciclovirs, herpes HSV1, 2, Epstein-Barr, ganciclovirs for CMV, okay, and a nice, I don't know if anybody knows the cocktail when somebody comes down with herpes simplex 1 actually, or simplex 2 now, but vanciclovir, which is Valtrex, you can give 1,000 milligrams BID Q12 for 2 days, and that pretty much can wipe out the worst cold sores ever. If you get it at first, you know how you have the tingle with the cold sore. If you get it with the first tingle, usually do your patients, they will love you, because that is definitely a treatment that works. And I actually give people refills on that, like 1 or 2 refills. Um, Everything can cause a side effect. I recently had a young guy come in, and he clearly had a herpes lesion. He had had the same partner for a while. He was really upset. This was a primary infection. He didn't know if he got it from her, if he got it from someone else. So I wasn't quite sure before I sent him for the test. So what I did with him was I gave him the treatment of Valtrex, which was 1,000 milligrams BID for 7 days actually. And then I also gave him Doxy. I gave him a script for Doxy as well in case it was some other kind of infection. So a lot of times that ends up happening when you're troubleshooting too. We're giving an antiviral and an antibiotic, which is kind of scary. Okay. Okay, herpes, shingles. If you start the therapy for shingles within 3 days of the outbreak, you need to check renal function. Oh, you need to start herpes shingles therapy within 3 days of the outbreak. You always need to check renal function before prescribing, especially in the elders. So that's any antiviral. It's usually acyclovir for herpes. Um, it's 5 or 6 times a day. It's pretty intense. It just shortens the course. It doesn't really get rid of anything. I don't think they understand that either. They get a little bit upset with you that they're not completely cured. Okay, so always with the antivirals, BUN and creatinine with high-risk patients. Always make sure your patients are drinking tons and tons of water. Another antiviral, of course, is Tamiflu. Tamiflu is only good if it's given within the first 48 hours of the sickness, and it's only good for influenza A. You see so many people prescribing Tamiflu for influenza B, and that is not the right drug for B. And B is much milder than its brother A, so most people don't really need a treatment for B. It's influenza A that causes all the issues. Once again, must be started within 48 hours of the treatment. More about antivirals, the Azole, the antifungals. Amphotericin B is something that's IV. And for the test, they love griselfulvin, so we'll go over that a little bit more in the actual individual audio review. So once again, you're seeing these CYP 450s again, and probably wondering what they are, and we will get into that. Like I said, we'll get into it if it's needed for the review, but we'll get into it in depth in week 4, and that's all you'll be assigned for week 4 is to listen. You're not going to have to comment or anything. This is just great information that you need to know. All the azoles have been associated with hepatic toxicity, so you always need, with all the azoles, you need to check AST, ALT, alk-phos, and bilirubin. Always. Okay, so what do we use antifungals for? Candida is your big one, your tinnias, your athlete's foot, things like that. Alright, so all your azoles, I just told you about your liver functions. And your systemic azoles. That's what I clicked on, and it just went south here. Okay, once again, you're just always going to have to watch any of your antifungals with AST, ALT, alk-phos, bilirubin, all the time. Okay, so there's only one. Okay, so these are killing pinworms and things like that. And just read. Okay, Flagyl. We use Flagyl for a lot of things. Bacterial vaginosis, C. diff, trichomonas, a lot of things we use them for. Okay, and this can be oral or IV. Alright, part of the H. pylori. It's on the $4 list at Walmart, so it's a cheaper drug. So the big thing, the take-home way point is you're giving this for people that are usually younger, say for somebody who has bacterial vaginosis. You want to make sure your patient knows to avoid alcohol when they're on Flagyl, because they will have a severe reaction. And right now that's it for your antibiotics. It's just touching on some points. In your review, I'll go through the systems. We're going to go through ears and everything, what you need to do. We'll talk about ear infections in kids and watchful waiting, things like that. Mostly though, like I said before, you need to know your pathogen, you need to know your description, meaning your gram stain, is it positive or negative, then you need to know what to pick, right? You need to know what kills what, you need to know if it gives off that beta-lactamase, you need to break through that, and that's how you're going to treat your patient. But, I mean, I guess we should say if you have someone who has a gram-positive pneumonia, you should think right away that it's strep pneumoniae, right, and what you're going to treat with. Or if you have somebody who's gram-negative and they have pneumonia, and they have H flu, and if they have H flu, you're going to think, they're possibly what? What are they going to be if they have H flu? Possibly a smoker, right? So things like that. So once again, know your pathogen, your description, meaning your gram stain, and then what your diagnosis is, and are they going to be drug resistant or not, too, is another thing. It gets easier and easier and easier. Your first few times it gets you're kind of perplexed. It's always pretty challenging when somebody comes in and they tell you that I'm allergic to penicillin, I'm allergic to sulfa, I'm allergic to Cipro, I'm allergic to cephalosporins. I mean, believe me, there's people like that, and you just want to cry. So we'll go over some more things like that. This is just a basic, an overview of the antibiotics right now. So read the PowerPoint closely, read your readings in the book, and I will be posting something very soon. Thanks.